First of all, welcome tonight to the community education session, The Importance of Kidney Health for All Ages. My name is Craig Lindsay, and I'm a member of the Scarborough Hospital Community and Patient Advisory Council. And here tonight with me, my colleagues Ali Ladek and Jim Perrant, as well as many other members of this committee council. We're here to welcome you, and we're your hosts for this evening. The Community and Patient Advisory Council, if you're not familiar with it, is comprised of 13 community members, which represent the very diverse communities and neighborhoods within Scarborough. We are, in effect, the voice of patients, their family members, their caregivers, and the broader general interest of the community at large. We report monthly to the Scarborough Hospital, providing feedback from these communities about the effectiveness and the issues around the programs and services that the Scarborough Hospital offers. One of the other things we do is community engagement and education, hence why we're here tonight. You're going to hear 4 10-minute presentations, very brief and to the point, from a group of specialists in the field of nephrology, which, if you aren't aware, is the branch of medicine and pediatrics that deals with your kidneys, keeping them healthy and how to treat them when they're not doing what they should. Following the presentations, we're going to have about half an hour for community members to ask questions. And at that time, you'll be able to address the panelists directly. To begin with, I'd like to introduce my colleague Ali Ladek, who's going to read the biographies and introduce our willing panelists tonight.
Thank you, Craig. Without further ado, allow me to introduce you to this evening's panelists. Dr. Paul Tam, Medical Director, Nephrology, the Scarborough Hospital. Dr. Paul Tam is a staff nephrologist at the Scarborough Hospital and the founding Medical Director of the Scarborough Regional Nephrology Program, a post he has held since its inception in 1996. A strong advocate for easier access to dialysis and renal care, Dr. Tam manages one of the largest home-based dialysis programs in Ontario. He is a former chair of the Ontario Association of Nephrologists and section chair of the Nephrology Specialty for the Ontario Medical Association. In addition to his passion for nephrology, Dr. Tam is heavily involved in community services as a director for the Care First Seniors and Community Services Association and supports the Scarborough Chinese Outreach Committee. Dr. Peter Azopardi, Medical Director and Chief of Pediatrics, the Scarborough Hospital. After graduating from medical school at the University of Toronto, Dr. Peter Azopardi completed a pediatric fellowship at the Hospital for Sick Children in 1989. That same year, he joined the pediatrics department at what was then the Scarborough General Hospital and was named chief of the department in 1993. Dr. Azopardi's commitment to the community led him to open a practice in Scarborough and to take on a medical directorship within the hospital maternal newborn child care program service group. Further to his on-call duties at the hospital, Dr. Azopardi regularly sits on pediatric care panels across Ontario and the Greater Toronto Area. Paulette Lewis, nurse practitioner, Nephrology, the Scarborough Hospital. Paulette Lewis is a nurse practitioner working full-time at the Scarborough Hospital's Chronic Kidney Disease Clinic. She graduated from Yeovil College with a Master of Science in Nursing in 2004 and completed her nurse practitioner course at the University of Toronto in 2007. Paulette's caseload entails working with patients living with stage 5 chronic disease. Her role focuses on patient self-management, including preparing patients to make the decision regarding modality options. Paulette is also the designated independent dialysis coordinator as defined by the Ontario Renal Network. In her role, she spends 2 days a week in the in-center dialysis unit located at the hospital's general campus, educating patients and assessing their eligibility for home dialysis. Veronica Javert, social worker, nephrology, the Scarborough Hospital. As a registered social worker, Veronica Javert practices solution-focused counseling in the nephrology program at the Scarborough Hospital. Since graduating with her Master's of Social Work in 2011, she's worked to further the profession by teaching others as an adjunct professor at York University's School of Social Work. In addition to her passion for social work, Veronica contributes to the hospital's quality improvement initiatives by working to understand the reasons behind a patient's late decision-making in seeking health care and has implemented strategies to address this through the development of decision-making support tools. Sam Watt, social worker, nephrology, the Scarborough Hospital. Sam Watt is a nephrology social worker at the Scarborough Hospital. He currently focuses on kidney patients who are on home dialysis. Sam actively promotes a healthy lifestyle and kidney health education in the community. As the president of the Chinese Renal Association, a chapter of the Kidney Foundation's Ontario branch, he has delivered talks on kidney health promotion at health fairs and on television and radio. For the last 2 years, he and members of the Chinese Renal Association have collaborated with the Trillium Gift of Life to raise awareness of organ donations within the Chinese community in the GTA. Sam graduated from the University of Hong Kong with a master's degree in social work. He also has a master's degree in theological studies from Tyndale Seminary in Toronto. I just want to add something, if I may. Before we begin, I would like to remind everyone to please hold your questions or comments until the question and answer portion of the evening following all of the presentations. At this time, I'd like to welcome Dr. Paul Tan, to the podium to begin our evening.
I think you can all hear me, but I'll speak to the mic. Again, I think tonight I have to behave myself. I don't usually do it very often. I'm being taped. So one of the things that I do want to, I was reflecting on this as I was driving here. There's a lot of the disease, they call it the heart and stroke, whatever day or week. Now, how come kidney needs a month? It's a whole month. So that reminded me, when I was first come to Scarborough, I was hired by Dr. Jack Stein, who unfortunately passed away a couple of years ago. Very nice man. He hired me out when I was in the University of Toronto. And I come up here and he said, Paul, you have to figure out a way of making a living. I say, really? That bad? He said, well, you know, when you have kidney disease, people don't know they have kidney disease. When you have chest pain, you ask to see a cardiologist. When you have bowel problem, you ask to see somebody. When you have kidney disease, nobody knows anything about it, which is true. It took me a while to find out that a lot of the doctors in those days do not regularly check urines. And the Chinese patient come to me for sex problems because the Chinese believe the kidney is the source of their, sex. So it's completely all these misunderstandings that it needs a lot of education. And through the years, we still do. It's not as common out there to know, and you need to literally has to help your doctor or help to look for it. So I think after tonight, hopefully there is some further understanding, and I appreciate you, ladies and gentlemen, coming out tonight. Now, I prepared a few slides. Okay. So they give me a few hints that say, talk about the function of the kidney. A lot of the people out there misunderstood. They say the kidneys, the function, how come it's different from the bowels? The bowel we eat, and we can see that we have to go for a bowel movement, and then we go to the urine. So why is the separate? The bowels, a lot of things that come out from the bowel movement is nothing that enters into our body. It didn't pass through our inside the body at all. They pass through the guts, so that's the waste that comes out. But what comes out through the kidneys has gone through a process of what we call metabolism. It's got absorbed in different parts of the gut, and then the useful things got taken up, and then the waste got dumped back into the bloodstream, and then they carried to the kidneys. And the kidney is a very smart organ. That's why I always argue with my cardiology friends. The heart is just a pump, I said. The kidney knows what they need and what the body don't need. It regulates the amount of water you drink. You can drink a lot. If your kidney is fine, you'll get it out. But having said that, you have to have your kidneys too. You can't just go overdo it with a lot of things. So this is a term that we use in physiology called homeostasis. Homeostasis means it regulates the body to make the internal environment constant. And it's not only that, it secretes a number of hormones too, which I haven't put it in there. One of which makes the blood generated in the bone marrow. We call it erythropoietin. So for those who are kidney patients know that at a certain time they need an injection of a hormone to help them. Otherwise they will get anemic. Their blood count will go down. And they also responsible for a lot of vitamin D3, which is important for controlling the calcium, the bone, and everything. So the kidney is actually a very smart organ. I'm not saying the heart isn't. The heart is also pretty smart, but I think the kidney is the smartest. It's also important to be working with other parts of the body, because of maintaining the internal environment. The most important example is the heart. If you drink in too much water, you ingest too much sodium or salt, if the kidney doesn't get rid of it, the heart will be under a lot of stress. And a lot of things will occur, high blood pressure and a whole lot of other things. So I can answer further questions later. But that's the introduction of why we say the kidney is an important and smart organ. What do we do at Scarborough? Well, when I started here, actually I started earlier in 1996, it's 1982. In those days, kidney programs, again, because there are not too many people aware of the problem or the scope of it, they are usually concentrated in university centers. You know, University Health Network, it used to be called Toronto General Hospital, St. Michael Hospital, and all that. And do you believe it or not, the next kidney program, east, I always say east of St. Michael's Hospital, you have to all the way drive to Kingston. In between, there was nothing. So for many years, you know, we fought for something that we should get it here, a lot of things. But we got it. The proof of the proof is we're now probably the largest program, not just in Ontario, but in Canada. So we have a lot of patients in our area, and I'll tell you some of the reasons later. And even today, we have to fight for a lot of programs, not just in nephrology. Dr. Asupati is fighting for his, and we are fighting for a lot of the things here. And that's why educating the public is so important. That so we work together. We have to lobby. You have to lobby for yourself. When doctors go and lobby something, they think we have something to gain. But you know, it's you are the important part. You will be helping us to help you. So what we do here, we have a home dialysis program, as you heard, all this dialysis program. That's for people whose kidney function is what we call life support, because it's a renal replacement, the kidney no longer works. But we also has the biggest program, what we call the Chronic Kidney Disease Clinic, which Paulette works and trying to draw the patients in before the kidney get to a point that no longer function. We try to make sure that there is enough function for as long as possible. Now, there's a lot of reasons your kidney fails. I'm not getting into all the disease tonight, but there are a lot of things we can help before the kidney fails. And there's certain times we can even prolong it so long that the patient never get onto dialysis. So that's an important thing to know. And we, of course, we have home program, we have called in-center dialysis program, we have it out there so that the patient doesn't have to drive. We even have dialysis program in nursing homes, so that the nursing home patients do not have to put on an ambulance to come to the hospital. And we are one of the first that did that in Canada, in Ontario definitely. And one of the things I want to point it out here, I was able to put that going here with the support of the Chinese nursing homes at the beginning. So I think they understand the community, and I think that's again illustrates the importance of the community working together. Our program not just treat patients. One of the important aspects is things like what we do here, trying to educate the public, to look for problems, try to help themselves, help us too. Before, so educational program, community activities, we go out to go exhibits. We work with organizations like Care First, literally going to apartments to test for blood pressure, protein in the urine. Those are works that very worthwhile, and we pick up a lot of things, and it was bigly supported by the LIMS. So as a nephrologist, as a kidney specialty, we maintain an office practice. And then again, in the CKD program, those nice ladies and that gentleman over there just go out regularly, doing talks, working on foundations, raising awareness, raising money, doing a lot of the things. That's what we do. Okay. So what do we do in the hospital? Again, I think I pointed out together. But one of the things too is we interact a lot with the family doctors. We do regular sessions. When the family doctors have educational sessions, we go and talk together. We work together with the cardiologists and the endocrinologists, because our biggest portion of patients these days come from diabetes. When I started my practice, I can tell you, there were maybe 10% of my patients are diabetics. Now it's approaching 60%. So that's why, there's a lot of education out there. renal replacement, I talk about dialysis. We also talk about transplantation. Transplantation is, you heard a lot about the wonderful things. If you get a kidney, especially you watch TV, you get an organ replacement, you think this is the, rejuvenation. Life is not as simple as that. There's still a lot of work before the transplantation. There's a lot of work for the patient and for everybody after transplantation. But we do those work as well in collaboration with the transplant centers. In the city is Toronto General Hospital, or UHN and St. Michael Hospital. They are the two transplant centers. But we do a lot of workup. We have regular meetings. We propagate education. And then what I call acute kidney injuries. Don't forget, a lot of our patients have chronic kidney disease that probably arising from, like I said, complication of diabetes. But we also have a huge number of portion of patients that have kidney failure due to other things, like after surgery, like a severe infection, like motor vehicle accidents, trauma. All those type of things also is very, very important. That we making sure that the patient will recover from all these complications. So I think, what are the particular challenges, as the public here? One of the things that here is there are a lot of newcomers in this community. Again, like I said, when I started my practice here, majority of the patients here are the old WASP type of patients. They come after the Second World War, work in the Golden Mile, settle in Scarborough, and then as time goes on, changes. The face of Scarborough is completely changed. But the good thing is, the staff's faces also change. I was one of the first change. Joking aside, when I started at Scarborough, I was the only Dr. Tam. Now we have 5. And I can assure you, Tam is not the most common name in Chinese. So you can tell how different the world has changed. A lot of times, I'm sorry to say that I can't even pronounce some of my patients' names. Standing in the office and say, boy, this is 16 letters, how do I do it? So anyway, this is all good. I mean, it gives us a really life in the thing. I came out from the meeting from the Ontario Renal Network yesterday. That's the agency that control the dialysis funding and the renal care funding. The thing is, they say, the rest of the country, the incidence of kidney failure going on dialysis is decreasing. It's only in Ontario. And I can tell you, we make up a huge of those numbers. The other one is Brampton. And I don't have to tell you why. You look around the reason, there's a lot. Yes, we have a lot of seniors here. We also have a lot of newcomers here. The newcomers come here that it's a different type of disease burden that sometimes that is not been, I hate to say that, not looked after properly, in their home countries before they arrive. And we have to do a better job to look after them as soon as they come, to make sure that the disease doesn't progress. Diabetes is one, hypertension, high blood pressure is the other, and also that in adjunct to this, there's a lot of lifestyle changes that, we call it sometimes the Coca-Cola and McDonald's disease, because the change of the diet makes a lot of the difference too. To look after this group of patients, the challenges are custom and language, family support, access to service, and a lot of them have economic challenges. It's not without accident that the two of them sitting there are social workers. A lot of the work that we have to do, we have to start with the patient's home. Okay. To take for example, one of the things that I insist on doing, and they know that, is before I start a patient at home dialysis, we insist on making sure, or start, or even educated, we insist they have to do a home visit. The home environment needs to be the right environment. Otherwise, we set ourselves and the patient up for failure. Okay. So, our incidence of disease is very high in high incidence of kidney disease, and I can tell you, a lot of that is due to diabetes. In the in this province at least, the higher incidence of diabetes is in Brampton. Incidence per population. Okay, not without incidence. There's a lot of South Asian over there, but the biggest number per together as a borough is in Scarborough, because we have much more number of patients and newcomers. You group it together than Brampton. So I'll stop here. I think I exceeded my assigned time, but if there's any question, I'm happy to answer it later. Thank you very much for your attention.
So thank you, Paul. I'm Peter Ezeparty. I'm the Chief of Pediatrics, as you heard earlier. And I'm a pediatrician, and I don't think I've ever been confused with a sex worker or a sex expert or any of those things, at least not yet in my career. But I have had people think that I was a foot doctor because I thought pediatricians had feet. And I do remember one time coming into my office and being completely deflated when I walked in to this little toddler and his mother, and I said, I'm Dr. Ezeparty, and they said, then the little guy burst into tears. He said, I thought I was going to a birthday party. These are part of some of the disappointments of my career, but in any event, I'm here to talk a little bit about kidney disease, and let's see if this is working. That's your thank you, and that's healthy kidneys start with kids, not just the letter, but the children themselves. There's a funny little thing, Hello Kidney. I never saw that before until Kidney Month, but that's on the internet if you look it up. So I'm going to talk a little bit about kidney disease in childhood, a little bit about some of the problems that happen in children that lead to adult disease, and then also talk a little bit about our Healthy Outcomes program that did take some lobbying with, and we're lucky enough to get funding for it with Scarborough Hospital and a joint venture with our friends at Rouge Valley. I'm going to try to skip through some of the details. I think I got heavily into kidney disease one night when I was doing this, and so I'm going to try to gloss over some of the details. So there won't be a test at the end, I can guarantee you. Most children with kidney disease are silent, and this is what Paul was saying. The kidneys are very smart, and they know how to look after themselves until they get into a lot of trouble. And in most kids, even the most common problems that affect the kidneys are very silent problems. So a child with a urinary tract infection, very common, I see lots of those. Until age 2 or 3, until age about 7 or 8, those children don't have the same symptoms that adults would. They don't feel burning when they pee. They may go to the bathroom more often, but if they're wearing a diaper, who knows? Same thing with getting up at night. They don't get up at night. They just pee in the diaper or in the bed, which is a common thing in childhood. So even a simple thing like a urine infection is not so easy to pick up in a child. And it's not until we see children getting quite sick that we realize that the kidneys might be in trouble. And we do see children with chronic kidney disease. And most of these children, to be honest, are handled at Sick Kids by a nephrology team. So we don't have a pediatric team for nephrology out here in Scarborough, but all of the pediatricians, all of the family doctors see problems that lead to kidney issues, and I'll list some of those as well. So it's only the children that actually get to this stage are quite rare. And we see more of those children in families that are challenged by both poverty and by socioeconomic class and high ethnicity ratios. So this is a list of things that can cause kidney disease, and some of the common ones are actually obstruction to the kidneys that can happen while the baby's still developing in the uterus, and then can end up completely destroying the kidneys before the baby is born, and that leads to severe problems at birth. You can get something called reflux, where the urine starts going backwards up to the kidney instead of being ejected from the bladder into the toilet the usual way. And then you can get kidney injuries, things like recurrent infections that can cause damage to the kidney over time, or just a very bad period of dehydration, which can cause the kidneys to go into failure just because there's not enough blood running around to make the kidneys work. We see a large number of premature babies, and we also see a large number of small babies that should be larger than they are when they're born. So the babies that are under 2.5 kilos or about 4 or 5 pounds, when they're born at term, often those kidneys are abnormal, as are some of the other organs in the child. But again, it's very silent. They don't come out waving red flags that saying, I have kidney disease. The heart is smart in a way because it tells us that they're in trouble. The children look blue. And so it's pretty obvious that we have to do something right away. The other things are quite rare. The kidneys are smart enough to adapt to damage to one part of the kidney by putting blood flow and using the healthy parts of the kidney, but unfortunately over time that also will cause damage because it's overuse of the healthy part of the kidney, which they're not meant to do that long term. And progression will lead to severe kidney disease, and luckily we do have transplantation capability at SickKids, and there is a bit of a preference to get children with this type of kidney disease, this more severe problems, onto transplantation. Dialysis has even, is a complicated thing in adults, and it's very complicated in children who don't follow routines very well and run all over the place and grab food and pull tubes out and do all sorts of things. So there is a push to get children into dialysis, into transplantation programs earlier. There's some things here about what we can do to prevent kidney disease, and the folks asked me to talk about that. And I think, some of the simple things are making sure that our pregnant moms are having fetal ultrasounds. Fetal ultrasounds have completely revolutionized how we find problems with babies' kidneys. And before it used to be, and I remember being taught at SickKids, you have to examine the abdomen of a newborn very carefully because the most common cause of a problem in the kidneys is a mass in the abdomen. Well, for a kidney to be that big, to feel it with your hand, things are horrible. So we're picking up a lot of really minor problems because our prenatal ultrasounds are so good. Obviously, we want to avoid drugs that can cause the damage to the kidney. When children have kidney disease, we want to monitor their weight, monitor their lipids, watch their blood pressure, and make up for problems like Paul mentioned, like anemia and bone problems, which can have severe impacts on growth for children. And then we strive to make sure that they have access to proper replacements if their kidneys are failing, whether it's dialysis or transplant. So there's a child in all of us, and some days I have my child running out a little bit more than I should be. But these three things that Paul's already touched upon, hypertension, diabetes, and obesity, are major problems. And it's not just an adult disease anymore. We're seeing much more of all three of these things in children, and it's a frightening statistic. We now, one of the scariest things I heard driving along, of course, the health of the CBC gives me great health information, but they said this generation of children are going to live shorter than their adults, and that's never happened before in the history of modern human development. To have lifespans actually now dropping. Why? Because of these three things, particularly the one on the bottom. So we've got guidelines now for what's normal blood pressure in a 5-year-old and in a 12-year-old and an 18-year-old, and when do you actually intervene with treatment, which is something that when I was taught pediatrics was something that rarely, if ever, happened. It was 1 or 2 pages in a book and just pass out over. The fact that now we screen for blood pressure in children, again, not much of that was happening. Diabetes, whether it's needing insulin, which doesn't usually have to do with obesity, but more scary is the number of children who are so obese that they're actually running into type 2 diabetes because their body is just resisting all of the insulin that they're making, and they have adult type onset diabetes. We're seeing huge changes in that number. And then I think the scariest thing is the rates of childhood obesity. So we're seeing rates that have doubled in the last 20 years, that our children are getting fatter, and Canadian children, unfortunately, are some of the fattest in the world, actually. 30% of Canadian children are overweight and obese, and that definition is based on, it should be 15%, is just how you define it, because the population should remain under that. The population is so big now that it's, we need, if we keep judging the population by what's normal, everybody's going to get bigger, and that's not appropriate. Of the children with type 2 diabetes, 95% of them are obese, and we're seeing more obesity in children who are in socioeconomic straits. And as Paul said, it's the quick hamburgers, the fast food. It's much more expensive to buy fruits and vegetables than it is sometimes to get junk food. So in Scarborough, we estimated that there were at least 25,000 children who are in the overweight category. That means heavier than 85% of the population should be, sort of a body mass index. And the obese population is actually 14,500 children just in Scarborough. And that's the children that are above the 95th percentile of that BMI. So these are pretty scary figures, and it's a lot of children. And up until recently, we really didn't have much to help them with. You'd come to the doctor, I'd hand out Canada's Food Guide, which is back there. I'd tell them the recommendation about activity, and I'm glad to see some of the posters back here because it's a message that I don't think we get out very well. You know, what do you think is the amount of physical activity that's recommended for the average child between age 5 and 11? It's an hour every day of either moderate to vigorous physical activity. It means you have to get the heart rate up, you have to be sweating, and you have to do that for an hour for a child every day. That's not an easy thing to do in today's culture. To try to tear them away from this, right? We've got really well exercised thumbs in our culture, and get them off this is not so easy. And you know, as parents, it's not easy for parents to even to sort of reflect that good behavior, so their model that good behavior, so the children pick up those habits as well. Luckily, we were able to lobby for this program, and it's just started in the last year, and we've been able to put together a multidisciplinary team to help deal with childhood obesity. We took obesity out of the title for a good reason. Kids don't want to be identified with the sort of obesity program, and a lot of our children will go right up to age 17. And this is focused on families, and we bring the parents in. Sometimes we bring the grandparents in because they are often the ones that are doing the cooking and the watching. And we have them seen in an intensive program by the group of specialists here, a dietitian, exercise specialist, a social worker is extremely important, nurses, pediatricians, and luckily we have a couple of pediatric endocrinologists who can help us out with complications of obesity. And for the small kids, we really just focus on teaching the parents and trying to set up some educational things, but there's a much more intensive program for the older kids. So they go through a 6-week program where they're seen once or twice a week for 6 weeks, and then there's a 2-year follow-up to try to instill good behaviors. And this is hard. This is really hard. We have these sorts of programs don't work very well, honestly. They have only about a 20% success rate, but there's nothing else that even comes close to 20%, so this is what we offer at this point. We were lucky to be one of 12 in the province to get funding for this, so we're proud of that, and we hope that we'll continue doing that funding for our families in Scarborough. So when I came to the hospital, not like Paul, I was actually not the first doctor at the party at the hospital. My father was at the hospital already, so people knew how to say the name already. Yeah, and he was also a pediatrician. And he spent his life talking and we spend a lot of our time talking about this. And what's funny is that a lot of kids will come in with a lot of medical problems, but obesity isn't recognized as a really major medical problem. And I'll try to explain to the mother that, you've seen a lot of my sick chronic kids out in the waiting room. I'm most worried about your child because your child is the one I can't treat effectively. I don't have any magic pills or, a wand to wave to make that obesity go away. And so I think this is something that we're hopeful that we'll be able to correct. You should spend some time reading the posters at the back, particularly the comments on the little kids on how to make their kidneys healthy. Our team went out to a school and got some comments, and I really like the one that says, I really shouldn't hold my pee. So I think that's good advice for everybody, and I'm going to head to the chair. So Paula Lewis is going to take over.
Good evening, everyone. I'm so honored to be here. Thank you for inviting me to speak. Hopefully you can hear me. Good. I'm a little bit challenged, so let's see. Nope, I'm going the wrong way. There we are. So I'm going to be using a patient case to help you to understand a patient's journey through our kidney clinic, or chronic kidney disease clinic, which is simply called the CKD, or the kidney clinic at TSH. I'm also going to speak a bit about my role as a nurse practitioner at the Scarborough Hospital. I'm going to discuss self-management briefly. So I'm going to introduce you to Brad. Brad is a patient that was seen in our clinic. He's 45 years old. He's married. He has 2 beautiful children, and he works as an auto mechanic. Unfortunately, he has not been able to work over the last 2 months because he's been very tired and just not feeling well. He has a history of diabetes, high blood pressure for the last 15 years. And he was sent to our nephrologist's office to be seen from his family doctor. Brad's sugars are not well controlled. He has sugar readings of about 10 on most days. Normal sugars should be 4 to 7. And he also has high blood pressure. When you have diabetes and kidney disease, you want to have your blood pressure around 130 for the top number. But his is about 160, 150 most times. So I want you to take a look at his blood work. On my my right, I guess, you'll see his normal level. So creatinine is 590, and this is how we measure the kidney function, just how well the kidneys are working. Hemoglobin, Dr. Tam spoke earlier about a special injection that some of our patients receive when their blood is not, when their blood level is low. And so that's called hemoglobin. That's what allows you to be able to go to work, to be able to do your daily function. And his is very low. If you notice, it's supposed to be between 135 and 175 for a male, and his is only 90. There's potassium, calcium, and phosphorus. These are minerals that we need daily to function. They're all abnormal. And his kidney function is only working at 8.2%. What does that mean? Out of 100%, only 8% or 8.2% of his kidneys is working. Or you could look at it at each minute. There's supposed to be 95 to 120 mils of blood that flows through our kidneys to keep it clean. But for him, only 8.2 mils is flowing through each minute. So Brad is quite sick. So unfortunately, Brad is just one of the many patients that we see in our kidney clinic. There are 5 different stages to kidney disease, how it's monitored. And so my stage, where's the pointer? The one at the far end that says stage 5 is when your kidneys are working at less than 15%. The other one next to it, at almost 900 patients we have in our clinic, and theirs is working at about stage 4, so they have kidney function ranging from about 15% to 29%. And the stage 3, they are working at about 30% to about 50%. So we have over 2,000 or between 2,000 and 3,000 patients that's in our clinic that we see with kidney disease. At the Scarborough Hospital, we use what we call a multidisciplinary approach. What does that mean? It means that when a patient comes to our clinic, they're going to see many team members that's going to help them to manage their various health issues. The reason that we do that is that we find that when you do use a multidisciplinary approach, it actually helps to give patient enough knowledge to make changes, to slow down the progression of their kidney disease. It also keeps the family doctor in the loop. Dr. Tam spoke about family doctors as well. But every time the nephrologist sees patients, they dictate a note, and the doctors are also part of these notes. So whether it's a kidney specialist, whether it's a family doctor, a diabetic doctor, a heart doctor, they're also in the loop as to what's happening with this patient. Multidisciplinary approach also provides the patient and their family with the tools that they need to manage their health disease. And so I'm going to speak a bit about self-management, but it gives them the knowledge to be able to manage their diseases. So the multidisciplinary team involves the patients. They're a big part of the team, and the care provider or family member. In this case, that would be Brad's wife, the family doctor, and then the different specialists. Nurses. In our clinic, we have 7 nurses. We have 3 full-time dietitians. We have 2 full-time social workers. We have pharmacists. We have physician assistants. And we also have people that help you to get ready for dialysis should the need arise later on. So each time the patient comes to our clinic, we're pretty much looking at their blood work, their function. We're doing their diet, their blood pressure. We're checking to see what their last blood work looks like. So when we look at Brad, for example, their creatinine at 590, keep in mind that this is a waste that's in the kidney that's not being peed out, so to speak. So it's built up. So it's almost 5 times the normal, because the normal level is supposed to be between 60 and 110. So the first person he'll likely see is a nurse who will discuss what we call a sick kidney talk, and that's actually giving him information about what his kidneys does, how they should be functioning, and what we can do to prevent it from further deterioration. The potassium, calcium, and phosphorus are all abnormal, so the next person they'll see is a dietitian. I always tell my patient that this is a cornerstone to keeping your kidneys working, because if we're able to control the diet, that's going to help a lot. So when you look at his potassium, there are certain foods, for example, that are high in potassium. So how many people like oranges and bananas and all these nice fruits? Lots of hands. So poor bread can't eat that because its potassium is high and we need to get it down. If he doesn't control his potassium, it can actually lead to him having a heart attack. So this is very serious things that we have to change his lifestyle and give him enough information to be able to go home and make changes. The other thing is his hemoglobin is low, so the nurse as well as the pharmacy will also be a part of Brad's team that day, because the pharmacist will have to tell him about this medication that Dr. Tam spoke about that's going to help to raise his blood level. And the nurse will teach Brad how to give this injection himself. Most often they get it once per week or every 2 weeks or so. So I'm going to speak a little bit about my role as a nurse practitioner. I want to say thanks to my nephrologists who've always been very supportive of the role. As a nurse practitioner, I do work very closely with the team and with the nephrologist. I manage a stage 5 patients, but I'm also able to do certain things. I'm actually able to adjust medications, write prescriptions, order blood tests. I prepare patients for dialysis. I write their dialysis orders in collaboration with the nephrologist as well. And I follow up in patients who might have started dialysis without having a plan in place. So I see them on the floor and try and make sure that they are educated enough about their choice and what kind of dialysis to choose. I also work, the second part of my role is with Dr. Tam spoke about the Ontario Renal Network. That's like our governing body that looks after our funding and so forth for kidney disease. I work with them as well. I'm the coordinator, and basically my role is to speak to patients about home dialysis, making sure that the right patient is on the right modality choice. I have to do certain reports for the ORN as well. So you want to make sure that if a patient starts dialysis without having the education, that they are provided with the opportunity to learn about the different types of dialysis so that they can make a decision that's going to fit their lifestyle. So I want to speak briefly about self-management. Self-management is a practice that's really encouraged at Scarborough. And basically it's defined as the ability of a person to deal with all that a chronic illness entails. So that includes any symptoms, any treatment, physical and social consequences, and any lifestyle changes that this disease entails. You know, when patients have a chronic disease, kidney disease, diabetes, or what you may have, they are only seeing the healthcare practitioner for a very short time. You go to your doctor's office, you probably spend 15, 20 minutes. They come to the clinic and they learn, but they have to actually be able to take this education home and self-manage the different diseases or conditions that they have. So Kate Lorig is one of the experts that speaks about self-management, and she spoke about 3 different categories where patients have to self-manage. They have to be able to take care of their illness. So if we look back at Brad, he's got diabetes, he's got high blood pressure, and he has kidney disease. So he has to learn how to check his sugar, make sure his blood pressure is in that good range. He has to know the foods to eat, be able to take that education that we provided at the clinic home and practice it on a daily basis. He has to also carry on with normal daily activities. He's a husband, he's a father, and he's a primary breadwinner. So we need to help him to also be able to continue in these roles. Now, emotional changes. Having any chronic illness can be quite depressing. As a matter of fact, research shows that patients that have a chronic illness suffers from depression about 25 to 35% more than those who do not have any chronic illness. So when you see someone who has kidney disease or they learn of their kidneys failing, oftentimes there's depression, there's anxiety. How am I going to support my family? Am I going to live to see my kids grow up to go to school? And so we have to provide them with a tool. Now, Veronica and Sam are going to speak about their role in supporting patients like Brad. So this is just a quick list of all the things that patients have to self-manage when they have chronic kidney disease. They have to learn how to preserve their kidneys. They have to monitor their blood sugar. Sometimes, you know, as the kidneys get worse, they may get swelling in their legs and they may get short of breath. So they have to learn how much to drink, and they have to monitor their fluid intake at home. So that includes soup, water, whatever. That's liquid. They have to learn how much to drink in order not to end up in the hospital. If they're diabetic, they have to learn how to check their blood sugar. If they have low blood sugars, they have to know how to treat it. Medication, there are certain medications that they're taking that they have to learn they can't mix them. They have to learn when to take it at what time. They have to learn how to make positive changes. Exercise, that's very important for them to continue to live normally. If they smoke, they have to somehow try to quit smoking. And they have to learn how to read labels and become almost like their own little dietitian and able to manage their health. So that's what self-management is all about. At the Scarborough Hospital and our CKD clinic, we try to empower patients. So we've developed what we call a self-management binder. There's one at the back if you get a chance to look at it. And basically provides patients with tools on how to manage. Inside of the binder is almost like a report card that the patients can bring with them when they come for their appointments. And they can actually mark and actually track how their progress is. So if their creatinine has improved or it's worsened, they can actually track their kidney function. They can track if their potassium is better and just how their health is doing. So we try to help them to self-manage this. For our patient Brad, one of the things that he had to do along his journey is to start making a decision about dialysis, because his kidneys are only working at less than 8% or less than 10%. We need to somehow, I call it the what if, we need to start talking about what if the kidneys continues to deteriorate? What do you want to do? How do you see yourself living? What's going to be best for you? Do you have someone to give you a transplant? If that's the case, then we're going to help him to work up and to go to St. Michael's or UHN for transplant. We're going to talk about the different types of dialysis, home dialysis, that he can have more freedom to be home with his family, to work, he controls his own schedule, or he can do his dialysis in center, where he comes to the hospital 3 times per week. Or hopefully not in this case, but some patients that we have do choose not to do any form of dialysis, but just to live their life until their kidneys are no longer functional. So not only do we have to look at the present with Brad, but we also have to look beyond and plan for the future. Thank you.
Okay, so as Dr. Tam had mentioned, Scarborough Hospital has a large nephrology program, if not the largest in Canada. And so we've been very lucky enough to have a large number of nephrology social workers. There's 5 of us altogether. There's 2 in hemodialysis who help manage the patients on hemodialysis in-center and outpatients. 2 in the chronic kidney disease clinic, both working in the outpatient setting and inpatient setting, and 1 social worker in the home dialysis clinic. So I'm from the chronic kidney disease clinic, and Sam is from the home dialysis clinic. Oh, thank you. Okay, so we're just going to give you all some education around nephrology social work. We don't just, there's a misconception about social workers that we take away your children and that we give you money. And those are the most 2 common stereotypes about social workers. And so today we want to talk to you a bit more about nephrology social work. So nephrology social workers support and maximize the psychological and social functioning and adjustment of patients experiencing chronic kidney disease or end-stage renal disease. This service is extended to families, caregivers, and their support networks. Support services are provided to improve social and emotional stresses resulting from the interacting physical, psychological, and social factors for a person living with CKD or ESRD, end-stage renal disease. Social work functions as part of an interdisciplinary team, as Paulette had mentioned, and is responsible, and we'd like to think we are responsible for fostering a positive treatment environment, policies, and routines that respect the diversity, including individual, cultural, gender, religious, and ethnic differences at the Scarborough Hospital, and more particularly in the Scarborough population. Nephrology social workers fosters and facilitates quality of life as perceived by the patient or as driven by the patient, their families, and caregivers by respecting their values of individuality, independence, and choices. We like to promote an overall wellness through all stages of care, including prevention, diagnosis, chronic illness management, treatment, and even end-of-life care. So when a social worker is referred to a patient, we try to assess the patient and create treatment plans that aim for positive health outcomes. This is done by working with the patients and their families by reducing the risk of psychosocial complications, delaying disease progression, promoting wellness, and facilitating links to appropriate resources. We accept referrals from patients, families, healthcare providers, community partners, or any other parties that may be involved in the patient's care. We triage, we assess, and manage high-risk and complex cases. Some of the examples of psychosocial risks and issues that social workers, nephrology social workers may be referred to and that we may be asked to screen include these items here. So I'm just going to read them out because they're quite a lot. So abuse, neglect, safety, assess the activities of daily living, which is what a patient or a person is able to do or have challenges doing. We also do advanced care planning with our patients and their caregivers. We assess for caregiver stress. If there's concerns around cognitive deficits, if there's concerns around coping, anxiety, depression, as Paulette had mentioned, grief, bereavement, and loss, we also are asked to see patients and families for. If there's concerns around family stress or conflict, finances is a huge reason for why we would be referred to see a family, and finances can stretch across a broad spectrum of issues that touch their lives if it's food, if it's housing, if it's source of income losses, for example. Health consent complexities, who would be asked to be decision makers, who are the people involved in those things. Assessment of home environment, as Dr. Tam mentioned. Illness management, immigration and settlement is also a huge part of the work that we do. Isolation, language and cultural needs, legal resources, medical benefits, mental health, rehabilitation, self-image, shelter, social support, substance misuse, transportation, treatment, decision support, and other complex needs. So as you see, it's not just taking your children or giving you money. And so I'll just turn it over to Sam to talk more about our assessment process.
Thanks, Veronica. Talk about the overview of the social work, our work. Of course, we are not dealing with all this. Otherwise, I don't think we have time to come tonight, right, to present to everybody about our work, right? So, the second part of my presentation is I just want to pick some important social work elements or our functions that will really impacting the patient who have kidney disease. And of course, the first things we usually will do is counseling and advocacy. Counseling here is that I think social worker, although we do have a good training background in terms of counseling, but we also know that social work is not a person who has magic wand, right? One person can put the magic on somebody and then we'll make everybody's problem solved. We cannot do that, okay? Although a lot of time we can do that, but sometimes we cannot do that. So that's why we need to like involving group, also involving people in our process in order to help. So that's why I think in Scarborough, in our dialysis program, especially home dialysis program, we have a very good peer support program, right? And they are very helpful because a lot of time peer support, one of few words is actually more important or more like kind of valuable, useful than we are saying so many words. So I glad that I work with a lot of patients in the home dialysis clinic because they also after they start they go through the experience and they're willing to share the experience with those people who still try to choose whatever modalities they're trying to choose. So I think that is a very important thing. And counseling is one thing, but a lot of time patients is not just like go through counseling. We also need to escalate it to advocate for them because this is like a system issue. And so a lot of time is we are not just talking about just the system within the government or whatever. It's also, we also see that they also have to deal with system with their workplace or even in school because we do have a lot of young people and they need to kind of advocate like their schoolwork. Sometimes because of dialysis, the professor doesn't understand, they need to do the dialysis at home, may not be able to deal with some of the workload, the school load. So at this time, we need to advocate for them. So that's why counseling advocacy is one of very important functions for the nephrology, to help the nephrology patients. The other thing is about promotion of chronic disease management. As Paul mentioned about chronic disease management and self-care is a very important things. I remember like when I was young, I remember like my mom always brought me to see the doctors, and then whatever the doctor said to follow, and then and then take the medication will be well, right? So all the responsibilities is the doctors, not us, right? And of course, on the other hand, there are people who are pretty think about their way to deal with their own things. They did not really kind of follow through the medical instructions. So that's why I think the chronic disease management and self-care is very, very important because through education, they know how to choose the information, how to manage their own disease through different things. In fact, a lot of patients, they have to learn how to deal with their problem, how to become more positive thinking, or even know how to using different way to address their depression. And actually, Veronica and I went through some sort of training from the Stanford model, the chronic disease management model, how to help people to deal with the day-to-day disease situation. And even every time when we finish we have a 6-week workshop, right? We have a co-leading a 6-week workshop, and then teach people different skills, different tools, how to deal with their chronic disease. And at the end of each section, we also ask them, make a goal, even a small goal, before the next week section, and try to achieve it. And then you can sense the success. And then through the success, they will try to proceed more, how to manage the disease better. So besides the manage the chronic disease, we also helping our patients to think about the advanced care planning. And we know that when people have sickness, they also need to think about the future. So who are their substantive decision makers? How to planning for the future. Those are the advanced care planning stuff. And usually we provide different information and also hints to patient, or even give them different kind of information, how to pick the person who help them to make the decision, when they are not able to make the decision in the future. And of course, education and teaching is one of our very major components. And so that's why we did do workshops for our patients and also to general public to let them know how to deal with the social situation. In fact, in Scarborough, I think we are, although the community is pretty good, but we are also restricted by the something called the social determinants, right? Of course, you heard about this term. In fact, there's some environmental things like income or even employment or health issue that affect people's health situation. So, as a social worker, we are trying to make use of this opportunity to educate our patients or even general public how to combat those social determinants so that they can actually improve their health situation or even improve their quality of life. And of course, community partnership. We did a lot of community partnership with our different agencies like Community Care Access Center, or even different local communities. I think Care First and even like different communities and even kidney foundations. We did a lot of partnership project with them. And in fact, tomorrow our peer support have a symposium, right? And they invite a lot of community stakeholders to come and providing different information to our patients so that they know actually in the community there are different things they can learn and then to how to help them to manage their own chronic disease. Now, the last of the least is that I think social work is also very important in cultural competence. We are very cultural sensitive. Remember in the Kidney Foundation's information, there are four types of people. They are high risk for kidney disease. One is the Southeast Asian, which is Chinese, and Lando Americans, and also native Indians. So I think in Scarborough area, I think the first two groups already been as like a major population. So you can see for us, we are dealing with not only English-speaking patients, we also deal with patients from different walks of life. So that's why we learn how we read, we go through different workshops to learn how to be how to help the patient in a cultural appropriate way. And so I think that is one thing I would also bring it up as well for our social work, working with our patients. So that's all, for our presentation, and thank you. So I think time for give it to Jim, right?